I'd like to take part 2 of the series on quality and patient safety and talk about creating value and the role of quality and patient safety in helping create value in the current healthcare era. Creating value is a real imperative in healthcare for the United States at the present time. We cannot afford the escalating costs that we see, and we can improve our outcomes. We think we provide excellent care. We do in pockets, but we do not uniformly across the country. And value really needs to address, number one, patient expectations. What do patients really expect us, the healthcare profession, to be doing? Secondly, payer pressures are really coming to bear, and this is the high cost of care. And some of this is the excesses of care. And then thirdly, it's provider responsibilities. What do we as physicians and other healthcare providers need to do to help create value? So that's what I'm going to touch on. Most of you have seen graphs like this or similar that emphasize the very high cost of healthcare in the United States. As you can probably tell by my accent, I trained in the UK, and they sit way down here, about half the cost percent of the gross national product coming in there. But most of the European countries are sitting down here. We are an outlier. And this is part of the huge imperative to create value in healthcare in the United States at the present time. We are moving to a new world. We are moving from what has been called a volume-based provision of care to a value-based provision of care. And the components of this are currently we are in a fee-for-service mode. We're moving to an outcomes-based mode. Payment is going to change based on how we perform rather than how many cases we do or patients we see. Incentives are changing. We have been incentivized to do more. That has given more money. That's not the way it's going to be as we move to this new world. It's going to be about outcomes again. And this is where creating this value becomes so important. The focus present time has been on acute episodes of care. And we have thought in those silos. Someone comes in with an acute appendicitis, you manage that bit of it. And really a lot of this comes back to who's really in charge of the patient overall. We each deal with our acute episodes. We're moving to an era where population health and management of healthcare populations is going to be increasingly important. So moving from these single episodes to a care continuum is what the volume to value move is about. And that's going to have to be driven by more predictive information flow rather than retrospective flow, where we look back what we did 6 months or a year ago and say we're going to do better. We need to know real time how we're performing and have more predictive information to drive patient care. So let's look at some of these components. What's really driving this change? A huge part of it is being driven by pay for performance. That's this value component in the reimbursement side of it. And there are 4 programs out there at a national level, a government level. I'm going to show you a little bit of these because it sets the framework of why value is so important. And these programs are as listed here: the Value-Based Purchasing Program, Readmissions, Hospital-Acquired Conditions. These are 2 penalty programs. And a new program coming in 2015 called the Physician Value Modifier, where physicians' payment is going to be based on how they perform. So we'll touch on each of these. Although this is for CMS, parallel things are happening with the commercial payers. So this is not uniquely CMS, but I will just focus on these ones. And the common theme in all of these programs, and you can see that a bit by the names, is around quality and safety metrics. It's about having metrics there that can be measured, that we are judged how we're performing to those metrics. First, the value-based purchasing program has focused on 2 things. First is core measures, and these are some of the process measures. These are, did I give the right antibiotic, the right drugs, did I do the right things for the patients in these process parts of care. And the second one is patient experience, and this is the hospital patient experience survey that patients, so this is patient collected data, they complete surveys, But the program that just came up this year for hospitals is 70% has been based on the process measures and 30% has been based on these patient experience scores. And there are baseline periods and performance periods, and then there's scoring about meeting expectations or exceeding expectations in an organized and logical way. I show this because this program is really changing. Over the next couple of years, it expands significantly. The process measures, so-called core measures, reduce significantly in importance. They drop down to 25% weighting from 70%. They're not very good outcomes measures, and that's why. Replacing those are some of the more outcome-oriented measures like mortality, death rates, hospital-acquired infections, and patient safety indicators. So these are much more clinically oriented measures that become a fairly significant part of the metrics used for value-based purchasing. This one up here, MSPB, Medicare Spend Per Beneficiary, is really beginning to get to the value part of the equation, the cost of care. And this is a metric that gives the Medicare spend per beneficiary for hospitals for 3 days before admission, during the admission, and 30 days after. This is getting a lot of press at the moment. There is significant risk adjustment within these metrics, the outcomes metrics and the spend metric. And as you can see, the weighting of how hospitals perform is really changing significantly from very basic things to much more appropriate and more complex things at the present time. The readmission reduction program, again, is the next important program, and this is a focus on 30-day readmission rates. Why? And really this is about transitions of care. We talked about episodes, going to continuum. This is it. Rather than just managing an episode of a patient for 3 or 4 days in their hospital, it is about, are you setting it up properly for this patient to be managed when they're dismissed from hospital? You have responsibilities for that. This is a good health system metric. The hospitals feel it's hard on the hospitals. I can't manage what happens when the patient goes home. But we've got to think as teams, not just my team, but teams from the patient perspective. So this is why this is important, because the overall readmission rate across the country is way too high at the present time. These are public metrics that are published on Hospital Compare, and this is the government website that puts all these metrics out for every hospital in the country. And this is for acute MI, heart failure, pneumonia, chronic obstructive pulmonary disease, stroke, total joints, and then all Medicare patients. So there are a lot of readmission metrics out there for public reporting at the present time. They're not all being used for penalty programs yet, but you bet you they will be over the next few years. And this is a penalty program. If you have 30-day readmission rates that are above the national average, you're going to lose money. And that risk this year is 1% of your overall Medicare payment. Starting October, it'll be 2%, and October next year, it'll be 3%. So there are potential escalating penalties if you have readmission rates above the national median. The 1%, 2%, 3% each of these years coming up. So half the hospitals in the country are losing money. The hospital-acquired condition penalty program is kind of similar to the readmission program. It's another penalty program. And these are the patient safety indicators and the hospital-acquired conditions. Remember, I showed you those sat on the Medicare Spend Per Beneficiary program. There's double jeopardy here. They're in 2 programs. I should have said the value-based purchasing program is budget neutral to CMS. Everyone puts a percentage in. It was 1% last year. It goes up to 2% over the next 3 years. And that money is redistributed. If you're above average, you're going to make a little extra. If you're below average, you're going to lose money. To the government, it's budget neutral, so they're not that interested in that program. It was getting things started. These penalty programs are now kicking in. And this one focuses on these 2 areas. And this is about the thing patients want most. It's about reducing preventable harm. And the metrics on here that are being penalized are the patient safety indicators, and there's 10 of those sitting there in a composite measure. We're not going into the details. These are the central line associated bloodstream infections and the catheter associated urinary tract infections and surgical site infections. Sounds familiar? These are important things, and these are things that by and large are preventable. And every hospital is working on reducing these and preventing these harm metrics. And it's about process and performance improvement, something we're going to come to. So this is a penalty program that will affect those hospitals who are in the lowest quartile nationally, and they will have payment reductions. And a bit akin to the readmission reduction program, these increasing potential penalties start kicking in 2015. So there's a lot of attention, and the importance of these in many ways is this is where everyone's focusing. This is where the performance improvement activity is really happening, and both of these are important for patients. The fourth one I had up there was this physician value modifier, and this is an adjustment to base payment for physicians starting in 2015, but that data is already being collected. Many of you have probably heard about PQRS, Physician Quality Reporting System, and the quality metrics that go with that. But there are actually 4 components to how the physician value modifier will be calculated. Currently, the metrics for PQRS are, I feel, in their infancy. A lot of them are primary care metrics. We at the Cleveland Clinic report as a group practice reporting option, and those are all primary care metrics. But what that means for us is that every physician at the Cleveland Clinic will have their base payment adjusted by how our primary care docs perform this year. That's a scary thought, but that's the way it functions. More metrics are on the slate to come in over the next 3 or 4 years in this space, into the specialty spaces. The other 3 things are here for certain sensitive conditions, unnecessary admissions, and these are things like sepsis, the things that you probably should have found out about and treated earlier, some of the heart failure things. So there's a group of conditions that your admission rates are being judged by, but also your overall 30-day readmission rates. And again, these are primarily in that primary care space. You see a recurring theme here. It's about trying to keep patients out of the hospital, and it's about trying to avoid harm and improve outcomes. And again, as for the Medicare spend, the value-based purchasing program with Medicare spend per beneficiary, the cost in this program is actually looking at for the patients attributed to you. And if you're the primary care doctor providing most of the care, that patient gets attributed to you no matter what other care they get. So you may be their primary care doctor, they get admitted to a hospital. That cost is coming back to you as part of this equation in this cost over a year of you compared to everyone else. So it's kind of wake-up time to think about this physician value modifier program. The penalties are not huge in this at this stage, but I can't help but feel there will be some increase in this space. So some of the things that are not really being addressed yet in value are these. Number one is kind of the appropriateness of care. And you've got to think about that in terms of the tests we do. Do they need this blood test? Do they need these x-rays? But also some of the procedures. We love doing procedures in the United States. Do we do too many? It is estimated that our overuse of medical care is in the 30 to 40% range. We've got to think seriously about that. As we move from this volume to value, I think we will see a lot more activity around decisions on appropriateness of care. Along with that comes reducing unnecessary variability. If you take a group of 10 physicians and look how they perform, you all perform differently. And beginning to understand that and looking and sharing best practices across groups is becoming increasingly important. And this is about eliminating waste at the end of the day. So how do we get there? It really is important in value to think about improving outcomes, the things we've talked about: safety, quality, and patient experience. Those are the pillars. A lot of the efficiencies, and this is about reducing the unnecessary variability, this efficiency is really important. Thinking about the cost of overall care, appropriateness we just touched on, But a lot of this is culture change. It's about creating value through teamwork. The day of autonomy has gone. You've got to think about teams. And it's not thinking about your team. As I often say, we talk a lot about teamwork, but we think about our team. If you're a patient, they're going from team to team to team to team. We've got to think how we create a team in continuity for a patient rather than shunting them from my team to the next team. So really, to sum this up, value is about quality and cost. On the quality side, how it's submitted safety, outcomes, and experience. It's about identifying those gaps, setting goals, and improving. Who owns this? We, the providers, own this part of it. This is where you need to be thinking about what can I do really to improve this part of the quality equation. The cost bit follows, but we've got to become increasingly sensitive to where costs sit. So that sums up my second section of this series on quality and patient safety for this master's series.